Hello everyone. Today we are going to learn about drug dosing in obese patients. It is a very important topic. So introduction includes obesity means excess body fat that affects individual's health. But in pharmacology, it becomes serious because it changes how drugs behaves in the body. That's why we need individualization dose to be essential. You can remember it as obesity affects both pharmacodynamic and pharmacokinetic and pharmacodynamic. So we must customize the dose. See, obesity is defined as a condition in which excess body fat has accumulated to an extent that it may impair health. It significantly alters pharmacokinetic and pharmacodynamic, which requires dose individualization. Now, how do we define obesity? According to WHO, we use the BMI classification. So, normal weight is 18.5 to 24.5, 24.9 BMI. Overweight is 25 to 29.9. Obesity class 1 is 30 to 34.9. Obesity class 2 is 35 to 39.9. Obesity class 3 is equal to or more than 40 BMI. How you can remember this? By using this mnemonics NO123. So we are jumping every 5 BMI units. So you have to just remember every 5 BMI units you have to increase. Now let's break down how obesity affects pharmacokinetics, that is ADME: absorption, distribution, metabolism and elimination. So in absorption it is good because this is mostly unchanged. Okay, but remember that gastric emptying time, gastric emptying time is delayed. So Tmax may increase, meaning that the drug takes longer to get to achieve peak concentration. Now here where it gets tricky in distribution. Lipophilic drugs means love fat. They spread more in obese people. So VD increases and we may need a higher loading dose. Example, we are taking diazepam. Now hydrophilic drugs stay more in water. They don't go into fat easily. So VD is slightly increased or unchanged. By seeing this table, you can easily write that distribution part that lipophilic drugs has more VD, example diazepam, propofol, and hydrophilic drugs are also have slightly higher or unchanged VD. Now obesity may increase or decrease, okay, increase or decrease, can increase or decrease the metabolism depending on enzyme activity. But one key point is liver size and blood flow increases. So for high hepatic extraction drugs, metabolism might go up. You can remember it as like CYP 450 enzymes may behave differently in obese patients. Now the elimination is mostly through the kidneys. In obesity, GFR increases, okay, meaning that renal clearance may be faster. That's why we don't use just TBW or adjusted BW, means uh, adjusted body weight or lean body weight for renally cleared drugs. Here we are not using TBW, total body weight formula, to give to adjust dose, but instead of that, we are using adjusted body weight or lean body weight formulas. What are they? We'll discuss later. Now, uh, we are calculating dose in obese patients. So, when calculating the drug doses in obese patients, it's crucial to use appropriate type of body weight depending on the drug's properties. So, here below we will discuss what are they. Firstly, we will discuss IBW, means ideal body weight. It is mostly used for hydrophilic drugs. So IBW have two formulas for males and females. So for males, 50 plus 2.3 multiplied by height in inches minus 60. Then for females, 45.5 plus 2.3 and multiplied by height in inches minus 60. Now let's talk about the TBW, total body weight. Here the patient's actual current weight is undertaken. Like if you are prescribing diazepam, so 2 mg per kg, like that you will prescribe. It is mostly used for lipophilic drugs which distribute in fat. Now next one we have is adjusted body weight. So it is used when the patient is more than 20 to 30% over their IBW, and the drug has partial fat distribution like aminoglycoside. Its formula is IBW plus 0.4 multiplied with TBW minus IBW. Now LBW means lean body weight. It is more complex and it is often calculated using a formula, but it is helpful for quick clinical use. So its formula includes LBW equals to 9270 multiplied with TBW, total body weight, and whole divided by 6680 plus 216 and multiplied with BMI. Now you can remember this by using this trick that you can use IBW for hydrophilic drugs, and you can use TBW and adjusted BW for lipophilic drugs. Think fat drugs need full weight while water drugs they don't need. Now this table is gold for Viva. So hydrophilic drugs use IBW or adjusted BW. Example, aminoglycosides and vancomycin. While lipophilic drugs use TBW, total body weight, and its examples are benzodiazepines and propofol. While NTI, narrow therapeutic index drugs, needs TDM and slow titration. Example, digoxin and lithium. So now we have given dose, but after that we don't stop after dosing. So monitoring is just as important as adjusting the dose. So we have to monitor uh, therapeutic drug levels, renal function, liver function, and clinical response. So you can think of TRLC. T means therapeutic drug levels to avoid toxicity and ineffectiveness. Then R means renal function, to adjust renally excreted drugs. And then L means liver function test for hepatically metabolized drugs. Then C means clinical response, that the drug is effective and safe. You have to monitor that. Then lastly, we have challenges. This is why dosing in obese patients is tricky, because there is no standard guidelines for many drugs, high risk for over or under dosing, and that's why we need uh, individualized therapy and TDM in many cases. And that's it for today. We have just learned everything about drug dosing in obese patients. We discussed the classification, pharmacokinetic changes, dosing formulas, drug types, and monitoring. If this helped you, like and share this video with your friends and subscribe for more videos.